Angiotensin converting enzyme inhibitor toxicity. Angiotensin converting enzyme inhibitors are among the most widely prescribed antihypertensive drugs. There are many ACE inhibitors approved by the FDA. In general, these drugs are well absorbed from the GIT, reaching the peak serum concentration within 1 to 4 hours. Enalapril and ramipril are prodrug and require hepatic metabolism to produce their active form. All ACE inhibitors have a common core structure of a 2-methyl-propanolol L-proline moiety. This structure binds directly to the active site of ACE, which is found in the lung and vascular endothelium, preventing the conversion of angiotensin 1 to angiotensin 2. Angiotensin receptors. There are many types of angiotensin receptors. Angiotensin receptor 1. This subtype is found in the heart, blood vessels, kidney, adrenal cortex, lung, and brain, and mediates the vasoconstrictor effect, while angiotensin 2 effects mediated by the angiotensin 2 receptors are suggested to include inhibition of the cell growth, fetal tissue development, modulation of extracellular matrix, neuronal regeneration, apoptosis, cellular differentiation, and maybe vasodilation and left ventricle hypertrophy, while angiotensin 3 and 4 play a role in the regulation of the CNS extracellular matrix as well as modulation of oxytocin release. Renin-angiotensin-aldosterone system is a hormone system that regulates blood pressure and fluid balance. So when renal blood flow is reduced, just the glomerular cells in the kidneys convert the precursor prorenin into renin and secrete it directly into the circulation. So plasma renin carries out the conversion of angiotensinogen released by the liver to angiotensin 1. Angiotensin 1 is subsequently converted to angiotensin 2 by the angiotensin converting enzyme found on the surface of vascular endothelial cells, predominantly those of lungs. Angiotensin 2 is a potent vasoconstrictive peptide that causes blood vessels to narrow, resulting in increased blood pressure. Angiotensin 2 also stimulates the secretion of the hormone aldosterone from the adrenal cortex. Aldosterone causes the renal tubules to increase the reabsorption of sodium and water into the blood, while at the same time causing the excretion of potassium to maintain electrolyte balance. This increases the volume of extracellular fluid in the body, which also increases blood pressure. Mechanism of actions. Angiotensin converting enzyme inhibitors. From the name, it implies block the angiotensin converting enzyme that convert angiotensin 1 to angiotensin 2. So, decrease the production of angiotensin 2, enhance natriuresis, lowers blood pressure, and prevent remodeling of smooth muscle and cardiac myocyte. Lowered arterial and venous pressure, reduce preload and afterload. Also, it is hypothesized that ACE inhibitors interfere with the degradation of bradykinin, which is a peptide which causes vasodilation. Under normal conditions, angiotensin has this effect: vasoconstriction and vascular smooth muscle hypertrophy induced by angiotensin 2 may lead to increased blood pressure and hypertension. Further constriction of the efferent arterioles of the kidney leads to increased perfusion pressure in the glomeruli. Also, it contributes to ventricular remodeling of the ventricular hypertrophy of the heart through stimulation of protooncogenes, and also transforming growth factors through fibrogenesis and apoptosis. Stimulation by angiotensin 2 of the adrenal cortex to release aldosterone, a hormone that acts on kidney tubules, causing sodium and chloride ion retentions and potassium excretion. Sodium is a water holding ion, so water is also returned, which leads to an increased blood volume, hence an increase in the blood pressure. Also, stimulation of the posterior pituitary released vasopressin, antidiuretic hormone, which is called ADH, also acts on the kidneys to increase water retention. If ADH production is excessive in the heart failure, sodium level in the plasma may fall, and this is a sign of increased risk of death in the heart failure patients. Also, a decrease in the protein kinase C. ACE inhibitors are available into three main groups depending on the chemical structure. First, sulfhydryl group, such as in case of captopril, dicarboxylic containing ACE inhibitors including enalapril, ramipril, lisinopril, and others. While third, phosphorus containing ACE inhibitor, of which there is only fosinopril. Adverse effect. These drugs are well tolerated and have very low incidence of side effect. Some reported adverse effects include rash, dysgeusia, neutropenia, hyperkalemia, chronic cough, and angioedema. About 1 to 10% well developed a dry, non-productive paroxysmal cough. Any patient who already has renal insufficiency is susceptible to worsening of renal function. So renal function need to be monitoring during treatment for susceptible group. ACE inhibitors may cause hyperkalemia, especially those at risk for this side effect prior history of renal impairments and or diabetes, stimulants, use of potassium sparing diuretics and or potassium supplement. Cholestatic jaundice or hepatitis is another serious adverse effect which can progress to hepatic necrosis and sometimes death. The drug needs to be discontinued and patient managed in the appropriate way. Cholestatic jaundice and or hepatitis is another serious adverse effect which can progress to hepatic necrosis and sometimes death. The drug needs to be discontinued and the patient managed in the appropriate way. Cholestatic jaundice or hepatitis is another serious adverse effect which can progress to hepatic necrosis and sometimes death. The drug needs to be discontinued and the patient managed in the appropriate way. The patient must then decide if they can tolerate it, a cough, and continue the medication. These drugs have been known to cause renal failure. Those with heart failure who depend on the renin-angiotensin-aldosterone system may develop change in their renal function with the use of ACE inhibitors. Also, about 1 to 5 of the patients with renal artery stenosis developed an increase in the blood urea, nitrogen, and creatinine. Angiotensin converting enzyme induced angioedema. Angioedema is an inflammatory reaction in which there is increased capillary blood flow and permeability, resulting in an increase in the interstitial fluid. So, if this process is confined to the superficial derms, urticaria develops, or if the deeper layers of the derms or subcutaneous tissue are involved, angioedema results. Angioedema most commonly involve the preorbital, perioral, or oropharyngeal tissue as shown in the pictures below. This swelling may progress rapidly over minutes and results in complete airway obstruction and death. This is the preorbital, preoral, the pathogenesis of acquired angioedema involve the multiple vasoactive substances, including histamine, prostaglandin D2, leukotrienes, and bradykinin, because ACE inhibitors also inactivate bradykinin and substance B. ACE inhibitors inhibition results in elevations in the bradykinin concentration that appear to be the primary cause of both angiotensin converting enzyme induced angioedema and cough. So there is no evidence that is angiotensin induced angioedema phenomena is IgE mediated. Although the literature is replete with the reports of angiotensin converting enzyme inhibitors induced angioedema, the overall incidence is only approximately 0.1% and it is idiosyncratic. One third of these reactions occur within hours of the first dose and another third occur within the first week. It is important to remember that the remaining third of the cases may occur at any time during therapy, even after years. Contraindications: the ACE inhibitors are contraindicated in patients with previous angioedema associated with ACE inhibitor therapy, renal stenosis, hypersensitivity to angiotensin converting enzyme inhibitors, pregnancy. Angiotensin converting enzyme inhibitor overdose. The toxicity of angiotensin converting enzyme inhibitors in overdose appear to be limited, although several reports of overdoses involving ACE inhibitors have been published. The majority of these cases reported manifested toxicity of co-ingestant. Hypotension may occur in select patients, but deaths are rarely reported in isolated ACE inhibitors ingestion. Other patients may remain asymptomatic despite high serum drug concentration. Toxicity: ACE inhibitors overdose are usually well tolerated, but significantly large dose can cause hypotension, which is prolonged. Also, ACE inhibitors block the aldosterone, which enhances potassium excretion of the body. When aldosterone is blocked, potassium can accumulate and sodium excretion is enhanced. Both lead to hyperkalemia and hyponatremia. Monitoring. Renal function and electrolytes need to be checked on a regular basis due to the effect of drug on the renin, angiotensin, and aldosterone system. Those with increasing potassium, blood urine nitrogen, and creatinine need to have the drug to be discontinued. Since ACE inhibitors can have an effect upon the liver, AST and ALT should be monitored. Treatment. Treatment should be focused on the supportive care and on the identifying any congestant that may be more toxic, particularly other antihypertensives such as beta-adrenergic antagonists and calcium channel blockers. In most cases, if the patient presents within 1 hour of ingestion and is awake and able to protect their airway, activated charcoal can be given. If they remain asymptomatic for 6 hours of observation, they can be considered to be medically stable for either to discharge or referral to a mental health center depending on the circumstances of the overdose. For those with hypotension, fluid should be the first line of their therapy. There is no antidote for ACE inhibitors poisoning, so naloxone have been used in captopril overdoses in the past with some success and can be tried if intravenous fluid are not successful. Also, vasopressor can be used for the treatment of hypotension. Naloxone may also be effective in reversing the hypotensive effect of ACE inhibitors. There have been a few published reports of overdoses involving this drug. Adverse signs and symptoms reflect the orthostatic or absolute hypotension and include palpitation, diaphoresis, dizziness, lethargy, or confusion. In a mildly poisoned patient, this hypotension may be treated with IV fluid alone. However, in the most severe cases, hypotension may require pressor therapy.